Welcome to Week 8, Chapters 7, 22, and 27. The time has never been better for a new breed of case managers, the direct-to-consumer, community-based case manager. The convergence of consumer-driven healthcare, wherein consumers take a more active role in decision regarding their healthcare, and the overburdened healthcare system has made the need for accessible, dedicated patient advocates more critical than ever. The rising costs of healthcare are further driving the need for professionals who are more directly involved and accountable to patients and patients alone. Although community-based care managers can focus interventions on patients and their families, they need to continue to foster positive, cooperative relationships with their patients, physicians, healthcare providers, and payer groups. A direct-to-consumer case manager needs to be able to envision themselves as their own boss and an entrepreneur providing case management services to members of the local community. Necessary traits include self-discipline, self-motivation, confidence, and organizational skills to manage their own business. Case managers existed as far back as the 1900s, where they served as care coordinators for patients requiring integrated multidisciplinary healthcare services. At that time, they were employed by public health service providers. Soon they entered another venue where their services were used in cases involving certain types of patients, such as low-income patients and those with mental illness or older patients. By the mid-1970s, the first generation of case management developed in the context of rehabilitation management. From there, case managers gained the attention of certain insurance companies that saw rehabilitation case management as a means to manage their cases more effectively and generate a new revenue stream. The advent of AIDS in the 1980s ushered into the next phase of case management. This disease, with its high cost of treatment and multidisciplinary requirements, was viewed as particularly well suited for case management and the associated risks designed to contain cost. All of the blame, however, cannot be placed on the shoulders of the carriers, the providers, and the system. Case managers must also assume some responsibility because they did little to articulate or highlight their intrinsic value. Now, with the parameters of the 21st century healthcare system and its dire need for change, there is a tremendous opportunity for case managers to be the agent of change and make a real difference. To serve effectively a change agent, direct-to-consumer community-based case managers must do the following: advocate for their role in the community, embrace an entrepreneurial can-do attitude, gain greater financial awareness about the costs associated with healthcare, assume the role of go-to person with patients and their family members, think globally while acting locally and staying connected to providers, employers, trusted advisors, healthcare advocacy groups, and nonprofit organizations. As in other entrepreneurial endeavors, there are advantages and disadvantages in going it alone, and one should evaluate them carefully before hanging out a shingle. Being given the opportunity for success does not automatically guarantee, nor does it be a truly excellent case manager guarantee profits. The benefits are numerous. As statistics bear out, case management has been and will continue to be one of the most effective tools in the growing array of cost containment and quality assurance tools in the marketplace today. There are drawbacks as well. When case managers leave an organization, they usually miss the camaraderie with colleagues and friends to have lunch with, discuss goals, dreams, commiserate with, and have fun with. In addition to those who shed a profession, case managers could draw off the departments and associated personnel to help them learn and develop upon their own area of expertise. When you are working to revitalize a case management department or start an independent business, the creation of a business plan should be your first move. The following is a list of important issues to address: the type of company, location, size, financial resources, short and long-term goals. Before becoming an independent case manager, you also need to access your personal skill set, know your strengths and weaknesses, envision the type of business, define your nature and personality, and decide what role you want to play. Every case management company, independent practitioner must consider others in the community who are in the same field. Competition is good. It keeps case managers on their toes and helps them stretch towards excellence. Because the business sector pays the largest share of healthcare costs, and close alliance between case managers and their concerned group is essential. The object should not only be to improve individual working relationships, but also increase the public awareness of case management in general. To keep their voices in the forefront regarding healthcare issues, case managers need to submit articles to business publications, join community business group coalitions to address healthcare concerns, and meet with business and healthcare leaders to tell them about the advantages of case management programs. Case management is much like other business and has many other of the same requirements. It is necessary to be aware of personal and business limitations and to contract or arrange for assistance in dealing with critical day-to-day management issues. Because even successful business experience peaks and valleys, having a plan to generate new clients is always important. When starting a business, it is very important to identify and accept the kinds of cases that present the most potential for success, both in terms of medical outcome and cost savings. Although we all welcome a challenge and want to demonstrate that we can do what others cannot, we do not want to attempt the impossible. This does not mean taking only easy cases. The easy ones do usually require case management. There are, however, many cases between the two extremes. Expressing appreciation for past and current business is important in maintaining ongoing associations and generating new referrals. Everyone defines success differently. For those who choose the entrepreneurial path, the ultimate goal may be the fulfillment of the work-life balance. Others may choose to grow and nurture something that reflects their passion. Our goals are often less about monetary issues and quality of life. Chapter 22, New Characteristics of Today's Healthcare Systems. Independent hospitals are becoming less the norm and more the exception. This is a function of both the incentives offered by the Affordable Care Act and the reduced use of inpatient care. The trend of healthcare provider consolidation is not expected to end anytime soon. For case managers, consolidation among providers can have a profound effect. Case management departments, which have many different names, will also be consolidated, therefore forcing some case managers out of their current positions. A decision-making power became more centralized and controlled by fewer entities. It becomes even more important for case management department supervisors and staff to strive for higher visibility and demonstrate the value of case management. As new models of care continue to grow and evolve, case managers will face new challenges, including those that test their professional ethics. We now have a wide range of healthcare models, from consumer-driven healthcare insurance plans such as high deductible plans to new healthcare delivery models such as PCMH and ACOs. The Affordable Care Act has played a significant role in the emphasis of accountability and the transition to value-based healthcare system. In April of 2013, an event was held to discuss how America's healthcare system would transition from its former value-based model to that of value-based to that of the value-based model. The report had some clear conclusions that ACO's incentive-based model outperforms the Medicare fee-for-service model in clinical quality and patient experience. Improving and standardized data from quality measures is essential, and more successfully transitioning to a value-based system will require a continued focus on improving patient health and well-being. The ethical challenges for case managers raised by the value-based model and its core goals come in several areas, most of which stem from the changes imposed by the Affordable Care Act. Must adhere to the rules of conduct they agree to when they earn their CCM designation. The patient-centered medical home, also known as PCMH setting, also introduces some new challenges for case managers related to medical errors and the heightened focus on quality performance and metrics with value-based healthcare. With a greater reliance on technology, case managers might find a high incidence of medical errors, a large percentage of which can be traced back to technology. The new quality reporting provisions on the Affordable Care Act, combined with the transition to value-based healthcare and the professional standards governing case managers, require medical errors to be reported. The increasing shortage of primary care physicians continue To characterize healthcare in America. Currently, more than 58 million Americans live in regions officially referred to as primary health professional shortage areas, areas in which the number of primary care physicians compared to an area's population is below federal standards. The growing shortage of primary care physicians can be attributed to the expanded health insurance covered by the ACA, along with the increase in the number of baby boomers who are aging. The sheer size of the baby boomer generation is expected to be one of the most significant forces affecting healthcare in America. Their longer life expectancies compared to their patients, coupled with high rates of certain chronic medical conditions such as hypertension, high cholesterol, diabetes, and obesity, will contribute to the rising cost of healthcare costs and the need for primary care services. As a result of the urging of the IOM, as well as the Advanced Practice Registered Advisory Committee and the Advanced Practice Registered Consensus Work Group issuance of its APR and consensus model in 2008, which was endorsed by more than 400 APR and stakeholder organizations. A goal was set to better align the licensing, accreditation, certification, and educational requirements for an evolving primary care role for nurse practitioners. Currently, nurse practitioners have full primary care practice authority in 20 states and the District of Columbia. Further, it is estimated that almost 90% of all the nurse practitioners are educated, trained, and ready to provide primary health care services. Chapter 27, Medication Management, a Case Management Call for Action. Polypharmacy can be simply defined as taking more than 5 medications. It can also include inappropriate medication use, such as the use of prescription or non-prescription medications that have no legitimate indication, the use of multiple medications to treat the same condition, the simultaneous use of interacting medications, an appropriate medication or dosage, and the use of medication to counteract the side effects of another medication. The aging process brings a myriad of medical conditions and chronic diseases, many requiring complex therapeutic regimens. Problems associated with medical medication use include noncompliance with drug therapy, over/under dosages, therapeutic duplication, off-label use, contraindicated use of medications together, drug-to-drug interactions. In addition, some medications can stimulate diseases. Polypharmacy often results because a patient is under the care of multiple physicians. In 2012, CBS News published an article of polypharmacy that outlined the issues with taking multiple drugs. The article notes that the percentage of people aged 60 years or older who take 5 or more medications has jumped from 22 to 37%. As defined by the Joint Commission, medication reconciliation is the process of comparing a patient's medication order to all the medications that the patient has been taking. The medication reconciliation process consists of 5 steps. Develop a list of current medications, develop a list of medications to be prescribed, compare the medications to 2 lists, make clinical decisions based on the comparison, and communicate the new list to appropriate caregivers. There are some ways for the case manager to avoid negative interactions when clients have a polypharmacy situation. 1, have them keep a list of all the medications, including vitamins and over-the-counter items. Go online. There are many websites where you can check what are the potential problems. Appoint a lead physician and ask the pharmacist. The opposite problem is medication non-adherence. The National Council on Patient Information and Education states that 40% of seniors are unable to read prescription labels and 67% are unable to understand information given to them. 32 million Americans are taking 3 or more medications daily. According to the Council on Patient Information and Education, nearly half of patients do not adhere consistently. Common behaviors such as forgetfulness and procrastination may result in the wasteful spending of $163 billion annually. The 10 most prescribed drugs in the U.S. are not the drugs in which we spend the most. 78% of nearly 40 billion U.S. prescriptions written in 2010 were for generic drugs. In 2010, the most prescribed drug was hydrocodone, generic Zocor, lisinopril, generic Synthroid, generic Norvasc, generic Prilosec, and hydrochlorothiazide. The drugs on which we spend the most money are those that are still new enough to be protected against generic competition. For many years, the world of pharmaceuticals has been very dynamic. The new drugs being developed at unprecedented rates and clinical trials following close behind. Over the past several years, we have witnessed deaths attributed to the side effects from FDA-approved pharmaceuticals that were used as prescribed according to the manufacturer's protocol. Case managers have the opportunity to assume a greater role in advocating and caring for their patients by becoming more proactive and informed regarding prescription medication, their side effects, and the potential for overdose associated with certain medications, in particular pain meds, especially when patients have comorbidity conditions requiring interventions and prescriptions to be made several visits and from a variety of settings. Case managers must be the voice of reason, advising and counseling to ensure that patients are fully informed about the potential risks and complications as well as the benefits. Case managers, unfortunately, are occasionally in the position of knowing that a medication is being used off-label, but because we see ourselves as patient advocates, we're reluctant to report the matter. The conflicting loyalties described here are vexing and are the reason why organizations need to establish ethical guidelines and committees to address such matters. The role of a case manager is a demanding and ever-expanding one. Keeping abreast of the many resources, including those of the pharmaceutical industry, is getting to be more complicated, but is an extremely important component of what we do. The value contributions to healthcare of the pharmaceutical companies cannot be underestimated, and I encourage organizations and individuals to take advantage of the many educational opportunities they make available to professionals and patients.